this wet, rattling, chest-shaking cough.
Oh, yeah.
It's visceral. It sounds painful. And if you're the one doing the coughing, it's just exhausting. It's the middle of winter. The sky is that flat, depressing gray, and you're lying in bed, staring at the ceiling at 2 a.m., wondering if that just a cold you had 3 days ago has, I don't know, turned into something that's going to land you in the ER.
It's the universal winter anxiety, isn't it? The upper respiratory stuff, the runny nose, the scratchy throat. We can handle that. That's an annoyance.
Right.
But when it moves down, when it settles deep in your chest and you feel that heaviness, that triggers a kind of primal alarm bell for people.
That is exactly where we're going today. We're taking a deep dive into the messy, wheezing, complex world of lower respiratory tract infections. We've pulled a huge stack of medical literature. We're focusing specifically on Chapter 43 from some of the core texts. And our mission is to decode the differences between these conditions that all sound alike but act very, very differently.
And it's a critical distinction to make. We tend to lump everything under this umbrella term chest cold, but scientifically, clinically, we're looking at a spectrum. You have to be able to distinguish between acute bronchitis, chronic bronchitis, bronchiolitis, and the heavy hitter pneumonia.
And frankly, I want to unpack the jargon. I want to know why my doctor won't give me antibiotics when I feel like my lungs are exploding. And I want to understand the actual mechanics of what is happening inside the ribcage. Why does one cough sound like a bark and another one sounds like bubbling water?
That why is fascinating. It's a story about anatomy, it's about microbiology, and it's about how the medical community assesses risk. Because as we're going to see, a cough isn't just a cough. The setting matters. Where you got sick matters, your history matters, and the specific bug involved, that matters immensely.
Okay, so let's map this out for everyone listening. We're going to start with what most of us just call a chest cold technically, acute bronchitis.
Right.
Then we'll look at the long-term struggle of chronic bronchitis, which is a whole different beast.
Completely different.
After that, we'll shift gears to the infants with bronchiolitis. And finally, we tackle the one that's actually the most common infectious cause of death in the U.S., pneumonia.
It's really a hierarchy of severity, and to understand it, you have to start with the sort of geography of the lungs.
Let's jump in then. Acute bronchitis. This is the one most of us have had. You get a cold and it heads south. What is physically happening in the lungs when we have this?
So to understand acute bronchitis, you have to visualize the tracheobronchial tree. Imagine an upside-down tree inside your chest. You've got the main trunk, that's the trachea, or your windpipe, that splits into 2 large branches, the bronchi, and then those split into smaller and smaller branches. In acute bronchitis, we're talking about inflammation of those large elements, the big tubes that carry the air.
So the pipes are inflamed, but not the final destination.
That is the crucial distinction. That's the dividing line between bronchitis and pneumonia. In bronchitis, the inflammation does not extend to the alveoli.
The alveoli being the little air sacs.
Exactly, the tiny grape-like air sacs at the very end of the line where oxygen actually gets into your bloodstream. In bronchitis, the air sacs are fine. They're open, they're dry. It's just the tubes leading to them that are swollen and angry.
Which explains why you can still breathe, even if it feels tight. Your gas exchange is working, but the plumbing is all backed up.
Precisely. The highway's under construction, but traffic is still moving, sort of. Now, environmentally, this flares up in winter. Cold, damp climates are a big trigger. But it's not just the weather. High concentrations of irritants, air pollution, cigarette smoke, industrial dust, all of that can precipitate an attack. The lining of those tubes gets irritated, raw, and reactive.
And once that irritation starts, there's one symptom that just completely dominates the entire experience.
The cough. It's the absolute hallmark of acute bronchitis. I mean, if you don't have a cough, you almost certainly don't have acute bronchitis.
Because it's not just a polite little clearing of the throat, is it?
Oh, no. This is a persistent, nagging cough. And what's interesting is it often starts early in the illness and then persists long after the nasal stuffiness or the sore throat is gone.
Right.
And the progression is classic. It usually starts non-productive, so it's dry, hacking, harsh. But as the inflammation ramps up over a few days, it becomes mucopurulent.
Mucopurulent. That's a fantastic, if slightly disgusting word. We're talking about phlegm.
We are. The infection causes the mucous membranes in the bronchi to become hyperemic.
Which means?
Engorged with blood and edematous, or swollen. This whole process leads to a massive increase in bronchial secretions.
And this is where the body's cleaning system fails, isn't it? I read in the notes about something called the elevator.
The mucociliary elevator. It's an incredible mechanism. Your airways are lined with these tiny hair-like structures called cilia.
Okay.
And under normal conditions, these cilia beat in unison, rhythmically moving a thin layer of mucus up and out of the lungs, like a conveyor belt or an escalator carrying away dust and bacteria. But in bronchitis, the virus is damaging that lining, the respiratory epithelium. The elevator breaks down. The escalator stops moving.
So you have way more slime being produced because of the inflammation, and the system designed to clear it is out of order.
Exactly. The secretions just pool there. They become thick and tenacious.
Tenacious sputum is a phrase that really sticks with you. It implies the mucus is fighting back. It's stubborn.
Yeah.
But here's the big aha moment for me in the research, and I think this is where the most friction happens between patients and doctors. When you have this nasty, tenacious cough, you immediately think, I need antibiotics, right? I need to kill the bacteria. I need a Z-Pack. But the literature is very firm on this.
This is the antibiotic trap. Patients want relief, and they equate antibiotics with a cure. But the vast majority of acute bronchitis cases, we're talking the overwhelming majority, are caused by respiratory viruses.
Viruses, not bacteria, so penicillin or amoxicillin won't touch it.
It's useless. It's like trying to unlock a door with a banana. It's the wrong tool entirely. The usual suspects are influenza, adenovirus, respiratory syncytial virus, or RSV, and the common cold viruses like rhinovirus and coronavirus.
So taking them just exposes you to all the side effects.
All the side effects, diarrhea, rash, allergic reactions, with zero benefit for the cough itself.
But we have to play devil's advocate here. It's never bacteria.
Well, in medicine, we never say never. There are exceptions, but they are specific. Mycoplasma pneumonia is a frequent bacterial cause. You might also see chlamydia pneumonia or Bordetella pertussis.
Bordetella pertussis, that's whooping cough.
It is, and that's a serious bacterial infection. But statistically, if you walk into a clinic with a chest cold in January, the odds are heavily, heavily stacked in favor of a virus.
So if I go to the doctor with acute bronchitis and they listen to my lungs and send me home without a prescription, they're not being dismissive. They're actually practicing evidence-based medicine.
They are. In fact, routine use of antibiotics for this is actively discouraged by every major medical guideline. It drives antibiotic resistance in the community, creating these superbugs we can't kill later, and it offers the patient nothing but a placebo effect and potential gut issues.
So what's the reality of treatment then? If I can't zap it with drugs, am I just doomed to hack for 3 weeks?
Well, it's largely symptomatic and supportive. Bed rest is real medicine here. Your body needs that energy to fight the virus. Fluids are critical. You want to drink enough to prevent dehydration, which helps decrease the viscosity of those secretions.
Make the tenacious sputum a little less tenacious?
Exactly. If it's thinner, you can cough it up easier.
What about the fever and the body aches, that hit by a truck feeling?
Antipyretics, aspirin, acetaminophen, ibuprofen, they help relieve the lethargy and that malaise. But, and this is a critical warning we have, to flag, aspirin should be avoided in children and teenagers with viral infection.
Because of Rey syndrome, right? I remember hearing about that as a kid.
Yes, the association between aspirin use in viral illnesses like flu or chickenpox and Rey syndrome, which causes this sudden catastrophic liver and brain swelling in kids, is well established. Just stick to acetaminophen for the little ones. It is not worth the risk.
Okay, so for the average adult, we rest, we hydrate, we wait it out. But is there a cutoff? At what point do we say, okay, I've been patient, but this might actually be bacterial?
The guideline is usually persistent fever or respiratory symptoms for more than, say, 4 to 6 days without any sign of improvement. If you're a week in and the fever is spiking, or you're actually getting worse instead of better, that's when we start to suspect a secondary bacterial infection.
So the virus might have weakened the defenses enough for bacteria to move in.
Precisely.
Got it. So the 4 to 6 day mark is the threshold for reassessment. Now let's shift gears. We're moving from the acute "I caught a bug this week" situation to something much more persistent. Let's talk about chronic bronchitis.
This is a different beast entirely.
Yeah.
While acute bronchitis affects all ages and is temporary, chronic bronchitis is primarily an adult disease, and it's a lifestyle-altering condition. The definition isn't based on identifying a virus or a bacteria. It's based purely on a timeline.
I found this definition really specific. It reads almost like a legal statute rather than a medical diagnosis.
It is a clinical definition. To be diagnosed with chronic bronchitis, a patient must have a chronic productive cough lasting more than 3 consecutive months for 2 consecutive years.
Think about that. 3 months out of the year, Every year. That's a quarter of your life spent coughing.
It's physically and socially debilitating. And crucially, to make that diagnosis, you have to rule out other causes like bronchiectasis or tuberculosis. If it's just the cough and the timeline and the lungs are otherwise structurally intact, it's chronic bronchitis.
And what does that look like day to day? The source material mentioned a very specific morning routine for these patients.
Yes, the hallmark is the expectoration of the largest quantity of sputum upon rising in the morning.
Which makes sense mechanically. You've been lying flat all night.
Gravity hasn't been helping you clear the lungs, and your cough reflex is often suppressed during deep sleep. So everything just pools in those inflamed tubes. When they wake up and stand up, the movement and the irritation trigger this massive clearing event. The sputum is tenacious, ranging from white to yellow-green. It can be mild, or it can be a severe, incessant coughing fit every single morning before they can even start their day.
And when we look at risk factors, there is one giant elephant in the room.
Cigarette smoking is the major driver. It paralyzes the cilia we talked about earlier and causes constant low-level chemical burns to the airway lining. But we also have to consider occupational dusts, fumes, and environmental pollution. And genetics play a role too. Host factors determine who gets it and how severe the progression is. Some heavy smokers never get it. Some moderate smokers get it very badly.
Now, in medical school, or even just in casual reading, you hear these old school terms for patients with chronic lung issues. For chronic bronchitis, the term is blue bloater. Can you sort of paint that picture for us? What does the physical exam actually show?
The blue bloater is a classic, if somewhat simplified descriptive term used to contrast with the pink puffer of emphysema. But for chronic bronchitis, blue refers to cyanosis.
Right.
Because the airways are so clogged with mucus and inflammation, gas exchange is impaired. The patient isn't getting enough oxygen into their blood, leading to a bluish tint to the lips or skin.
And the bloater part, is that just weight?
Obesity is often noted, yes, but clinically, it also refers to fluid retention. The lungs are so hard to pump blood through that it strains the right side of the heart, causing fluid to back up in the body. You also see a barrel chest.
I've heard that term. What causes the chest to literally change shape?
Air trapping. Because the airways are so narrow and clogged, it's easier to breathe air in than to push it out. Over time, the lungs stay overinflated. The rib cage actually expands and kind of fixes in that position to accommodate the trapped air. You might also see clubbing of the digits, where the fingertips become bulbous and round, which is a sign of chronic low oxygen delivery to the extremities.
That paints a vivid and honestly a pretty difficult picture of long-term suffering. So how do we treat this? If smoking is the driver, I assume stopping is step one.
Absolutely. Smoking cessation is the only intervention that definitively slows the decline of lung function. You have to remove the irritant.
Okay.
Regarding management, there's an interesting note on mucus. You might think mucolytics drugs designed to chemically break up mucus would be the answer.
Right, thin it out so you can cough it up, just like with the fluids in acute bronchitis.
In theory, yes. But the data shows they have pretty questionable therapeutic value in chronic cases. They don't significantly improve quality of life or slow the disease progression. Surprisingly, simple humidification of inspired air often works better.
So a humidifier beats a pharmaceutical intervention.
Often, yes. Just hydrating the airway makes the mucus less sticky. However, for patients with moderate to severe COPD, which chronic bronchitis falls under, we do use medication. We use bronchodilators, long-acting beta agonists, to open the tubes, often combined with inhaled corticosteroids to reduce the inflammation.
Now, I want to get into the Anthonison criteria. This sounds super technical, but it struck me as a really practical tool. Because unlike the acute folks who shouldn't take antibiotics, these chronic patients do often get them when they have a flare-up. How do doctors decide?
That is the challenge. Patients with chronic bronchitis live with a cough. That is their baseline. So how do you know when they have an infection on top of their baseline condition? We call this an acute exacerbation of chronic bronchitis. The Anthonison criteria gives us a checklist to cut through the noise.
Walk us through it.
We look for 3 specific changes from their normal. 1, increased shortness of breath. 2, increased sputum volume. Are they coughing up more than usual? And 3, production of purulent or pus-filled sputum.
And the rule.
If you have 2 of those 3 symptoms, the probability of a bacterial infection is high enough to warrant antibiotic therapy. It takes the guesswork out of it.
And if they do trigger that threshold, what bugs are we fighting? Is it the same as the acute list?
It shifts. Now we're looking at Haemophilus influenza, Moraxella catarrhalis, and Streptococcus pneumonia. And here is a scary detail. Resistance is a huge issue. Up to 40% of H. influenza and nearly all M. catarrhalis produce something called beta-lactamase.
Beta-lactamase, that's the enzyme that destroys penicillin, right?
Exactly. It's a chemical shield the bacteria produce. So if you get plain amoxicillin, the bacteria just chew it up. We
Yeah.
have to choose drugs that can bypass that defense, like adding clavulanate or using a different class entirely.
It really highlights that this is an escalating arms race between the drugs and the bugs. Okay, let's leave the world of chronic adult coughs and look at the other end of the age spectrum. Section 3, bronchiolitis. This is the one that terrifies every new parent.
It does, and for good reason. Bronchiolitis is an acute viral infection of the lower respiratory tract that targets infants. The stats are just staggering. It affects about 50% of children during their first year of life. By age 3, essentially 100% of children have been infected.
100%. So if you have a kid, you are going to deal with this. It's inevitable.
It is a rite of passage, unfortunately.
And who is the culprit here?
RSV, respiratory syncytial virus. It accounts for up to 75% of all cases.
Now, here's the question every parent asks. Why does RSV put a baby in the hospital when it just gives me, the adult, a cold?
It's a geometry problem. Bronchiolitis affects the bronchioles, the tiny, tiny airways leading to the alveoli. In an adult, those airways are wide relative to the inflammation. A little swelling is annoying, but it's manageable. In an infant, those airways are microscopic. A tiny bit of swelling or a tiny bit of mucus can completely block the tube.
So it's like clogging a drinking straw versus clogging a big drain pipe.
Exactly. The resistance to airflow increases exponentially as the radius of the tube gets smaller.
So what does it look like? How does a parent know this isn't just a cold, this is bronchiolitis?
It starts with a prodrome, a warning phase.
Hmm.
For 2 to 8 days, it looks like a typical cold. Irritability, maybe mild fever, runny nose, but then it moves down.
And that's when the breathing changes.
Yes, you see vomiting, diarrhea, noisy breathing. But the red flag is labored breathing. You'll see chest retractions.
Explain retractions. What are we looking at?
Because the airways are blocked, the baby has to generate this massive negative pressure to suck air in. The skin actually sucks in between the ribs and above the collarbone with every single breath. You can almost see the skeleton moving.
Wow.
You'll also see nasal flaring, the nostrils widening to grab more air. The baby is working incredibly hard just to breathe.
That is the nightmare scenario. So you
Yeah.
rush to the ER. As a parent, you want them to do something. You want a shot, a pill, something. What is the treatment?
This is the hardest part for parents to hear. Usually it's self-limiting. It requires no therapy other than fluids and reassurance.
Reassurance is a tough prescription when your baby is gasping for air.
It is agonizing. But unless the infant is hypoxic, meaning their oxygen levels are dropping or they're dehydrated because they can't eat, we just support them. In severe cases, oxygen therapy and IV fluids are the mainstays. We just have to keep them stable while their immune system fights off the virus.
I noticed the source mentioned a specific drug called ribavirin. Is that a standard treatment?
No, ribavirin is very niche. It's an antiviral, but it has significant toxicity risks and is incredibly expensive. It's considered only for a subset of very severe patients, those with, say, congenital heart disease, chronic lung disease, or severe immunodeficiency who might not survive the infection otherwise. It is definitely not for routine cases.
And again, just to hammer this home, because I know parents will ask, no antibiotics.
No antibiotics. Bacteria are rarely the primary pathogen in bronchiolitis. Giving antibiotics here just exposes the child to side effects and messes with their developing microbiome with no benefit whatsoever.
Okay. We have covered the annoyance of acute bronchitis, the chronic slog of the smoker's cough, and the scary viral storm in infants. Now we arrive at the final boss, Section 4, pneumonia.
Pneumonia, the captain of the men of death, as it used to be called. It is the most common infectious cause of death in the United States.
That is a heavy statistic. We tend to think of modern medicine as having conquered infection, but pneumonia is still a giant killer.
It is serious business. It hits the very young, the elderly, and the chronically ill the hardest. In pneumonia, the infection has breached that final barrier. It has reached the alveoli.
How does it get that deep? The lungs are supposed to be a fortress.
There are 3 main routes of invasion.
Yeah.
First, inhalation of aerosolized particles. Someone sneezes on the subway, and you breathe that cloud right down into the deep lung. Second, via the bloodstream. If you have an infection elsewhere, like a bad kidney infection or an infected heart valve, bacteria can travel through the blood to the lungs.
And the third?
Aspiration.
It's inhaling food or spit. Right?
Correct. Aspiration of oropharyngeal contents, stuff from your mouth or throat entering the trachea instead of the esophagus. This is a major route, especially in people who can't protect their airway properly. Maybe they've had a stroke, or they're intoxicated, or they're under heavy sedation. They inhale their own bacteria-laden saliva deep into the lungs.
Now, one of the most interesting things in the source material was the classification system. Before reading this, I thought pneumonia was just pneumonia. You have it or you don't, but doctors break it down by where you got it.
This is vital. We don't just ask what bug is it. We ask where has the patient been, because the setting predicts the pathogen. It's essentially a statistical game we play to save lives.
Let's run through the acronyms. CAP, community-acquired pneumonia.
This is the most common. You catch it at the grocery store, at home, at school. If you're an otherwise healthy adult, the bug is almost always Streptococcus pneumonia. It accounts for up to 75% of these cases.
Okay. Then we have HCAP, healthcare-associated pneumonia.
This is a tricky category. These are people who aren't in the hospital right now, but they have a lot of contact with the system. Maybe they live in a nursing home, or they go to dialysis 3 times a week, or they had home wound care recently.
Why does that distinction matter so much?
Because the bugs are nastier. These patients are floating in an environment where antibiotics are used constantly. They are at risk for multi-drug-resistant MDR pathogens. We have to treat them differently than the person who caught it at the grocery store, because we have to bring out the big guns immediately.
Then we have HAP, hospital-acquired pneumonia.
This is defined as pneumonia that develops more than 48 hours after hospital admission. So you came in for a broken leg, your lungs were clear, and 3 days later, you have pneumonia. You caught it there.
And finally, VAP, ventilator-associated pneumonia.
This develops more than 48 hours after intubation. This is the single strongest predisposing factor for hospital-acquired pneumonia, being on a machine. The tube bypasses all your natural defenses, the nose, the glottis, and provides a plastic highway for bacteria right into the lungs.
So the setting tells the doctor what antibiotic to reach for before the lab results even come back.
Exactly. It dictates the empiric therapy, which we can get to in a moment.
Let's talk about the experience of having pneumonia. We established that bronchitis is all about the cough. What's the classic presentation of pneumonia?
It's usually abrupt. With bronchitis, you might feel a slow decline. With typical pneumonia, you feel fine, and then boom, high fever, shaking chills, shortness of breath, and pleuritic chest pain.
Pleuritic pain, that means it hurts to breathe.
Yes, it's a sharp, stabbing pain when you take a deep breath because the inflamed lung is rubbing against the sensitive lining of the chest wall.
And visually, the sources mentioned a specific color of what comes up.
Rust-colored sputum. That is the classic description for pneumococcal pneumonia. It implies blood mixed with purulent secretions. It's not bright red, fresh blood. It's that brownish, rusty color of old blood coming from deep down in the alveoli.
And when the doctor puts the stethoscope on your back, what are they hearing? This part of the physics really interested me.
They're listening for consolidation. In bronchitis, the lungs sound loose and rattling. In pneumonia, the air sacs are filled with fluid and pus. They become solid. So when you tap on the back percussion, it sounds dull. Think of the difference between thumping a hollow drum versus thumping a bucket of water.
And there was this term, whispered pectoriloquy. It sounds like a Harry Potter spell.
It does. But it's a classic physical exam finding. Sound travels much better through liquid or solid than through air. If a healthy person whispers, 1, 2, 3, and I listen with a stethoscope, I can barely hear it. The air in the lungs muffles it.
Okay.
But if someone with pneumonia whispers, the sound transmits perfectly through that consolidated, fluid-filled lung. It sounds loud and clear right in my ear.
That is fascinating. The physics of sound revealing the infection, and to confirm it.
The chest x-ray. You look for dense lobar infiltrates, white patches where there should be black hair. That is the gold standard for diagnosis.
Okay, we know what it looks like, sounds like, and feels like. Now let's get into the nitty-gritty of the bugs and drugs in Section 5. We mentioned Streptococcus pneumonia is the big bad in adults. What about the others?
Well, there's a divergence between adults and kids. Adults are mostly bacterial. Children are mostly viral, RSV, parainfluenza, adenovirus. But there are some specific bacterial types that have unique personalities.
Like walking pneumonia. That's a term everyone uses, but what does it actually mean?
It's technically called atypical pneumonia, usually caused by Mycoplasma pneumonia. We call it walking because the onset is gradual. You aren't bedridden immediately with shaking chills. You feel cruddy, you have a low fever, and a persistent dry, hacking cough, but you might still be walking around going to work.
And the weirdest part was the list of symptoms outside the lungs.
Right, mycoplasma is strange. You can have ear pain, skin rashes, nausea, joint pain. The x-ray looks different too. Instead of that solid white block of consolidation, you see patchy infiltrates. It looks messier, more diffuse.
It sounds like a systemic infection that just happens to be in the lungs, too. Now, for the grossest detail in the episode, we have to talk about anaerobic pneumonia.
This typically comes from aspiration and inhaling those mouth contents we discussed. Anaerobic bacteria thrive where there's no oxygen, like deep in a blocked, pus-filled lung segment.
And the telltale sign?
Putrid sputum.
Putrid.
Highly suggestive of the diagnosis. If the sputum smells foul like rotting organic matter, you think anaerobes immediately. The type also tends to be indolent, meaning it moves slowly. But if untreated, it can lead to a lung abscess. It literally rots a cavity in the lung tissue.
Yikes. Okay, so you have a patient, they're sick. You have a guess at the cause based on whether they're from the community or a nursing home. How do you treat them?
We use empiric therapy.
Which is a fancy way of saying an educated guess.
It's a high-stakes educated guess. We can't wait for the culture results. That takes 48 to 72 hours. If you wait that long with severe pneumonia, the patient could die. So we start antibiotics immediately based on the guidelines for that setting.
So what are we using?
If it's community-acquired, we usually use a macrolide like azithromycin or a fluoroquinolone to cover strep and the atypical bugs. If it's hospital-acquired, we go broad and heavy to cover the superbugs like MRSA or Pseudomonas.
What's the goal?
Eradicate the organism and minimize organ damage. We want to see concentrations of the antibiotic and the respiratory secretions exceed the bacteria's breaking point.
And how fast should it work?
For community-acquired pneumonia, we expect clinical stability, fever dropping, heart rate normalizing within the first 48 to 72 hours. Complete resolution of the symptoms usually takes about 5 to 7 days.
That's pretty fast, actually.
It is, if you guess the right drug. If the patient isn't getting better in 3 days, you have to rethink everything. Did we miss a resistant bug? Is it actually a virus? Is there a lung abscess forming?
It really emphasizes why that initial classification, CFT versus HCAP, is so incredibly important. You have to place your bet on the right horse right out of the gate.
Exactly. And you have to consider the patient's comorbidities, diabetes, heart disease, kidney issues. All of that changes the risk profile and how aggressive you need to be.
So, bringing it all together, we have traveled from the upper airways all the way down to the deep lung tissue.
We've seen the hierarchy. You start with acute bronchitis, irritating, loud, but mostly viral and self-limiting, the don't take antibiotics zone.
Then chronic bronchitis, the smoker's struggle, where the structure changes and daily life is impacted by that morning routine.
Then bronchiolitis, the viral threat to infants where their own anatomy works against them, requiring supportive care and a lot of parental patience.
And finally, pneumonia, where the air sacs fill up, oxygen is blocked, and we need aggressive, targeted antibiotics based on the setting to save a life.
The common thread here, if you noticed, is the importance of accurate diagnosis. Treating a virus with antibiotics, whether it's a chest cold or bronchiolitis, does nothing but increase resistance and risk side effects. But missing a bacterial pneumonia can be fatal.
It's a really delicate balance. The body is amazing, but these bugs are clever.
They are. And here's the final thought to mull over. Consider the complexity of the lung itself. It has these incredible defense mechanisms, the alveolar macrophages, which are the cleanup crew, the mucociliary escalator talked about, the cough reflex. It's designed to be a fortress.
Right, it's supposed to be sterile down there.
But a simple virus, a tiny bundle of genetic material, can suppress those defenses. It impairs the macrophages. It stops the escalator. It effectively lowers the drawbridge for the bacteria to march in. It's a reminder of how interconnected our body's defense systems are. We tend to think of viral and bacterial as separate events, but in the lungs, one often paves the way for the other.
That is a sobering but fascinating place to leave it. The domino effect of the lower respiratory tract. Thanks for unpacking that on us.
My pleasure.
And to you listening, hopefully the next time you hear that rattle in your chest or your kid's breathing changes, you'll have a better roadmap of what's happening beneath the surface. Stay healthy, watch out for that rusty sputum, and we'll catch you in the next deep dive.